Okay, we're going to continue our talk about inflammation. And we're talking about chronic inflammation. We'll start with this diagram illustrating some of the events present in chronic inflammation. So we have here a bloodstream in which we could see the monocytes. This is a monocyte. The monocytes, when present in a case of chronic inflammation, they exit the bloodstream and get into the tissues or into the interstitium. And within the interstitium, they become called macrophages. The macrophages they become large and phagocytic cells called macrophages. Those macrophages are activated by the effect of gamma interferon. Gamma interferon causes activation of macrophages, which is secreted in turn by T lymphocytes. So when activated, those macrophages will release proteases, which play a role in destruction of tissue, and interleukin and tumor necrosis factor. Interleukin tumor necrosis factor will in turn activate T lymphocytes and B lymphocytes and natural killers. So the macrophages will release the interleukins, tumor necrosis factor, which will activate T lymphocytes, and the T lymphocytes will in turn activate macrophages. So we have this circle of co-stimulation between both. The interleukins and tumor necrosis factor will affect the B lymphocytes, which will produce the plasma cells, which generate the immunoglobulins, immunoglobulin G, and they will stimulate fibroblasts as well. So the interleukin, tumor necrosis factor, will stimulate lymphocytes, B and T lymphocytes, and they will stimulate the fibroblasts, which will produce the collagen. This is a section from a patient with chronic endometritis, chronic inflammation of the endometrium. And here we have the stromal cells of the endometrium, and in between you can notice those dark, small, round blue cells. Those cells with no or very little cytoplasm. Those are the lymphocytes. So we have the lymphocytes, and we have those larger, slightly larger nuclei with pink cytoplasm, and the nucleus pushed to one side, which we call eccentric nucleus. So this is a plasma cell. Those are the plasma cells. This is a plasma cell, this one, and this one, and this one. And we have the lymphocytes, which are components of chronic inflammation. So components of chronic inflammation are what we call mononuclear cells, composed of lymphocytes, plasma cells, and macrophages. And macrophages have rather more irregular shapes of nuclei. This could be a macrophage, it could be a stromal cell as well. This second was taken from a patient with chronic cervicitis, long-standing inflammation of the cervix. And when this inflammation lasts for a long period of time, and if severe enough, it could cause intra-tissue hemorrhage. So this is hemorrhage within the tissue. These red RBCs are infiltrating the cells of the epithelium, this epithelium of the cervix, as a result of severe chronic inflammation. And here you can see the small dark cells we talked about, which are the lymphocytes and plasma cells, components of the chronic inflammation. This section was taken from a patient with rheumatoid arthritis. Rheumatoid arthritis is another example of chronic inflammation. Here we have the synovial lining. This is the synovial lining. This is the synovial space, the synovial lining, and underneath you can see this large aggregate of dark cells, large nodular aggregate. Here we have another one, and here we have another one. So they are composed of lymphocytes as a result of chronic inflammation of the joint. This section is taken from a lung. If you can see, those spaces are the alveolar spaces. These white spaces are the alveolar spaces, and in between you can notice the septae, or the walls, which separate between them. And it was taken from a patient with influenza A infection, and so it's a viral infection. And viral infections usually, they more commonly cause chronic inflammation than bacterial infections. So this is one point to concentrate on. The other point is that if you can notice, the inflammatory cells, the small dark cells, small blue cells, are infiltrating the walls or in the interstitium. As opposed to acute inflammation, if this patient had acute inflammation or acute bacterial infection, let's say, you will see the neutrophils filling the spaces and on the surfaces of these walls, rather than inside the walls. So this is an important feature of chronic inflammation, in which you will find the inflammatory cells within the walls or within the tissue, inflamed. You could find a mixed picture as well. You could find acute in association to chronic inflammation at the same time. So here we have those lymphocytes and plasma cells, the dark ones, and at the periphery here at the other end, at the left, you can see those fragmented nuclei, those cells with fragmented nuclei, which are slightly more eosinophilic cytoplasm. Those are the neutrophils, component of the acute inflammatory process. So in this image, you can see acute and chronic inflammation, which we usually could see in other examples, such as acute and chronic cholecystitis, or acute and chronic cervicitis. So acute and chronic inflammation of the cervix or the gallbladder could give us such an image. So in these patients, he'll have chronic inflammation and with repeated or recurrent episodes of acute inflammation. So this section was taken from a lung with a patient with chronic inflammation, and the outcomes of chronic inflammation could end by resolution, a complete resolution, and going back to normal. The tissue will go back to normal, or it will leave a scar behind. So in this case, there is a scar left behind. This white tan tissue is collagenous tissue. This is the scarry tissue left behind after the chronic inflammation. And in between, you could notice those bronchi. After the inflammation, they became dilated and permanently dilated. So dilation and scarring as a result of collagen deposition, as a result, of course, of chronic inflammation. So this is a microscopic section. This is the bronchial space, and the bronchial lining is destructed at this end, at the left of the image, is destructed by this inflammatory infiltrate, which extends into the lumen. So this is an image, an example of destruction caused by chronic inflammation. This section of a lung, you can see it has 3 lobes, so it's a right lung. The upper and lower lobe are somehow normal. This is the normal, or somehow normal lung fields, and this middle lobe is white, looks dense, and it is fibrotic. This is due to scarring, fibrosis as a result of inflammation. So this was an abscess. This patient had an abscess in the middle lobe of his right lung, and it was left untreated. It wasn't open and it wasn't drained. So if you leave this abscess, it will turn into a chronic abscess. So it is possible to have a chronic abscess with elements of both acute and chronic inflammation. So this is a chronic abscess. This CT image shows us a patient with an abscess at the descending colon. Here we have the liver. This is the right side of the patient, and this is the left side. This is the transverse colon, and here we have the descending colon. At the side of the descending colon, you have this collection, which is well circumscribed. This is an abscess as a result of diverticulosis. This patient had diverticulosis, and one of the diverticulae ruptured and formed an abscess just next to the descending colon. So if you could view it under the microscope, you'll see this image. An abscess which is a collection of acute and chronic inflammatory cells. It could also have chronic inflammatory cells, as we said. And it has a wall. This is the wall of the abscess. And you can see there is something we call organizing wall. So the wall of an abscess is organizing. So it's forming newly formed blood vessels. Those small capillaries are newly formed as a result of organization or organizing in the wall. So we have ingrowth of capillaries filled with RBCs along with fibroblasts. The fibroblasts will deposit collagen, as we said, and it's going to replace the space of the abscess, or the cavity of the abscess. It will be all replaced by collagen fibers and fibrosis, which will eventually replace the whole abscess. This section was taken post-mortem from a post-mortem patient, from the heart of a post-mortem. At the left, you could see these normal muscle fibers, normal cardiac muscle fibers, here and here. But in the middle here, and the right, you see what we call granulation tissue which forms in the process of healing, inflammation and healing. So this patient had myocardial infarction to the muscle of the heart, and as a result, inflammation occurred and healing process started. And this is the tissue we will see in the area of healing, which we call granulation tissue. So back again to an abscess. This is the wall of an abscess, okay? And you will find organizing, as we said, newly formed blood vessels along with fibroblasts. And in the middle, in the cavity of the abscess, you will find this, what you call purulent exudate, or they call it clinically as pus, which is a collection of RBCs, inflammatory cells, and dead cells in the center of the abscess. Now back again to the granulation tissue. We saw granulation tissue, we said that it is involved in the healing process, or it's the tissue found in the area of healing. And let's take a look at the components of the granulation tissue. We have first the newly formed blood capillaries, or newly formed capillaries filled with RBCs. This is a newly formed capillary. This one, and this one too. We have inflammatory cells, chronic inflammatory cells such as lymphocytes, like this one. This is a lymphocyte. This one is a lymphocyte, and this one is a lymphocyte. We have plasma cells as well. So you can see this is a plasma cell, slightly larger than lymphocyte, but with pinkish cytoplasm. This is a plasma cell. And we have macrophages. This is probably a macrophage, along with fibroblasts. Those cells with elongated nuclei are probably the fibroblasts found here in the granulation tissue, with the meshwork in the background. This whole meshwork of fibers are the collagen fibers. So we have blood capillaries, inflammatory cells including chronic and sometimes acute. So here we have lymphocytes, plasma cells, macrophages, and fibroblasts, along with collagen fibers. This section is taken from a lung after a long-standing inflammation, chronic inflammation. So again, the alveolar spaces. In between we have the separating walls, but as you could see here, or if you could notice, the walls are very thick in comparison to the normal ones. Normally you have just 1 to 2 cell thick, but here we have thickened septi, or thickened alveolar walls as a result of chronic inflammation and deposition of collagen fibers within those walls. This is a gross image of a lung. This is a patient's lung, and the surgeon is pushing it away from the chest wall. Usually it is not attached to the chest wall. We have the pleural space in between. So this is the pleura, this is the parietal pleura, and this is the visceral pleura. And in between we have this connection in between, which is abnormal. This connection is composed of thin bands of collagenous connective tissue. So those collagenous connective tissue bands have formed here as a result of chronic inflammation and activation of fibroblasts, which cause adhesion of this lung to the chest wall. And this will in turn affect the expansion of the lung, its movement within the chest wall, and could sometimes cause retraction. This is a skin surface. This patient had a biopsy, skin biopsy. The doctors took a biopsy from his skin, from this area. As you can notice, this area is different from the surroundings. Here we have the newly formed skin, or epithelium. So it is thicker than the normal epithelium. And underneath you could see this area with different color from the surrounding areas. This is the granulation tissue, the tissue responsible for healing of the skin. So after a month, this patient is going to have a scar in this area on his skin. This is an example of granulomatous disease. Granulomatous disease involving the lung. As you can see, we have these white nodules, widely dispersed white nodules. Usually they affect the upper pole if involved in the case of pulmonary tuberculosis. This patient had pulmonary TB, and as you can see, the upper lobe of the lung is diffusely infiltrated by those white nodules, which are called granulomas. This is the lung of another patient with pulmonary TB, and in this case, there are no diffusely dispersed granulomas, but you could see this hilar lymph node. This is a hilar lymph node, largely expanded. It's a large lymph node involved by granulomas. So this is a hilar lymph node. Granulomas, due to infectious agents such as mycobacteria, they are often described as caseating. So caseating are granulomas with central necrosis, or central caseating necrosis, or caseous necrosis. This is a microscopic section. Now let's take a look back at the alveolar spaces. Here we have the alveolar spaces, and the walls are thin. So we have no component of chronic inflammation in the walls. But if you can notice, we have those large nodules, large nodular lesions. Those are the granulomas found in cases such as TB. So if you took an image for this patient, if you took an X-ray for this patient, it will be described as reticulonodular. So reticulonodular, the nodularity will be derived from those granulomas, but the reticular pattern will be derived from the air-filled spaces, which are the alveoli, normal alveoli filled with air. So this is the pattern they will see on images, reticulonodular pattern. If we take a look at a better view at the granulomas, here we have this well-circumscribed granuloma, and here we have another granuloma. So we have two granulomas. The granulomas are usually formed by what we call epithelioid macrophages. So macrophages which are epithelioid. Epithelioid means that they resemble the epithelial cells. They look like the epithelial cells. They have the cytoplasm of an epithelial cell, but they are actually macrophages. So we have epithelioid macrophages, we have lymphocytes, plasma cells, and fibroblasts, along with sometimes we could find those large cells with multiple nuclei, which are called multinucleated giant cells. This is a giant cell. This is an example of giant cells. This whole collection of nuclei are nuclei of one single cell, one single giant cell. This CT image of the patient will show us this is the lung of the patient, and within the lung parenchyma you can notice those four bright spots. Those are calcifications as a result of the healing granulomas. So granulomas, when healing, if you leave them to heal, they might form calcifications. Okay, in this granuloma, we have here the microorganisms found within the large multinucleated giant cell. This is a giant cell engulfing those microorganisms, and surrounding it, we have the rest of the granuloma. Those are other granulomas, but here we are going to just concentrate on this large cell. Those, both of the giant cells, are called Langhans type giant cells. So giant cells have subtypes, and one of which is called Langhans giant cells. If you notice, the nuclei are surrounding it at the periphery, at the very periphery of the cell. So this whole one is one single giant cell, and its nuclei are on the periphery of the cell, or the periphery of the cytoplasm. So this is called a Langhans type giant cell. This is a closer look, or a higher magnification of the granuloma. Here you can see the epithelioid macrophages. Those are macrophages. They are found usually in the center of a granuloma. So as we said, the name was taken from the fact that they have lots of pink cytoplasm resembling that of epithelial cells, or squamous epithelial cells. And their nuclei tend to be long, elongated, slightly elongated, or stringy. Those are epithelioid macrophages. Here we have caseating necrosis. This is a granuloma. This whole image is for a granuloma. And in the center, this pink amorphous material is the area of caseating necrosis, as we could find in tuberculosis. This is again an example of caseating necrosis. This area of the right upper corner is the area of caseous necrosis, and here we have the rest of the granuloma. So these types of granulomas, we can find them in tuberculosis, as we said, and other pathogenic fungi, such as Histoplasma capsulatum, Cryptococcus neoformans. So you should memorize those microorganisms as causes of granulomas: tuberculosis, Histoplasma capsulatum, and Cryptococcus neoformans. This is a case of miliary tuberculosis. Miliary tuberculosis is tuberculosis that has spread widely in the body or in the lung. This is lung miliary TB. So you can see the whole lung field is infiltrated by those small white nodules, which are small granulomas, 1 to 2 millimeter in diameter. So it is involving the whole lung field. It is called miliary TB. This is a food particle, some particle of a vegetable or something, which was aspirated into the lung. So when aspirated into the lung, the body will react to this particle as a foreign body, and in turn will cause an acute and chronic inflammatory process. So as you can see, surrounding this vegetable material, we have acute and chronic inflammatory cells. Here we have neutrophils, those small cells with segmented nuclei. Those are the neutrophils, components of an acute inflammatory response. And we have lymphocytes and plasma cells as well. And notably, here we have this large multinucleated giant cell with its nuclei, but in difference to those, to Langerhans giant cell we saw before, those nuclei are haphazardly arranged. They are not arranged at the periphery of the large cell. So these are called foreign body giant cells. So foreign body giant cell is a giant cell with its nuclei haphazardly arranged. Here we have another example of a foreign body giant cell. This was formed in response to this foreign body, which is a suture material left behind in the body of the patient. So we have this foreign body and a foreign body type giant cell. This is an image from a polarizing microscope. You can note those white, bright areas, which are crystals of talc. Talc is some kind of powder used to dilute drugs. So this was taken from a patient who is an IV drug user, and those crystals will formed within the lungs of this patient and viewed as such. Sometimes the inflammatory reaction is mainly one of scarring. So in this case, we have a scarring nodule, or a nodule with central scarring. This whole pinkish fibers are collagen fibers as a result of a reaction to silica particles. This patient had silicosis, so inhalation of silica particles, and when they reach the lung, the body will form such a reaction. And something specific to it is this dense pink collagen in the center of the nodule, which we call fibrosis. So a large nodule with central fibrosis or prominent fibrosis is a reaction for silica particles in a patient with silicosis. That's going to be all. Thank you.